Welcome, everyone. Today we'll be discussing the relationship between ADHD, attention deficit hyperactivity disorders, and substance use disorders, with a particular focus on alcohol use disorder. This is a relatively new and growing area of research, posing a challenge for all professionals working in the addiction treatment. The need to explore this topic in greater depth arose from some of our master's students. In response, we reached out to the International Research Network, ICASA, which aims to facilitate knowledge exchange and enhance both the quality and the quantity of research in this field. We are fortunate to have Dr. Luderer with us today. He is a member of ICASA, a specialist in adult psychiatry, and the head of the addiction unit at the University Hospital of Goethe University in Frankfurt. He also contributed several German guidelines on substance use disorders. And the organization is Dr. Luderer will talk about 30-35 minutes, and then we'll open the room for answer and questions. Listening to the presentation, you can start to pose your question in the chat. And now, another brief announcement. This seminar is organized in the EMDAS Master context, and I want to announce you that the new inscription are now open for the new edition that will occur in 2025 and 27. We will post some information in the chat as well, so that you can read and spread the information if you're interested. And now I'm pleased to hand over to Dr. Luderer. Matthias, the floor is yours.
Thank you, Sarah, for this kind invitation and the kind introduction. I'm talking about ADHD and alcohol use disorder, and I'm happy to take your questions afterwards. So these are potential conflicts of interest, mine. And I was asked to also talk about ICASA a bit. We heard about it. It's an international network, scientific network that exists for over a decade, and which is growing and prospering, and which is also very interested in finding new data, creating new data about ADHD and substance use disorders. This is the homepage. You can visit afterwards if you want to, or parallel if you're capable of that. We have almost 60 members now of 17 countries, 4 continents. So the only continent that we are not that we haven't found a member yet is in South America. The other continents are quite members are of other continents are members of ICASA. This is the board. I am board member since a year or so now, and the others have been much longer in the board, and they are quite well-known researchers. We are publishing a lot of different papers on the topic of ADHD and substance use disorders. And I think the two most recognized papers are these two here, consensus statements on screening, diagnosis, and treatment of substance use disorders with comorbid ADHD in adolescents and in adults. And this had also a very large impact on national guidelines and the German guidelines that I've been involved in. Let's start from the beginning. So go away from ICASA and the network and go back to the topic that we wanted to talk today about. ADHD is a neurodevelopmental disorder which has a very high heritability. 17 to 80% is heritable of this disorder. So it's quite large for psychiatric disorders. for a long time, we only had diagnostic criteria that were made for children or adolescents. But since DSM-5 came out, 2013, we finally had criteria for adults as well. So there are some symptoms of inattention or some symptoms of hyperactivity, impulsivity that needed to be fulfilled to be able to make the diagnosis of ADHD in adults. But we also know that there are many patients missed while they are still children or adolescents. So sometimes, not especially in substance use disorder treatment, very often we have to diagnose ADHD for the first time ever. And so we need to assess how the childhood symptoms were. And DSM-5 says we only need several symptoms before the age of 12 years. And it should not be better explained by other diagnoses. This is very important, and I will come back to that later. This doesn't mean that other diagnoses rule ADHD out, but the symptomatology, the whole bunch of symptoms should not be better explained by other diagnoses. ICD-11 has a bit more details, less strict criteria to offer what ADHD is like according to ICD-11. And this groups inattention or describes inattention quite nicely because it says that inattention is it's difficulty sustaining attention, which everyone knows, to tasks without high level of stimulation or reward. This is difficult for everyone, but especially difficult for individuals with ADHD. So if things get boring, then keeping up the focus and keeping up the attention just because you need to or it's important to you, that's very difficult for ADHD, individuals with ADHD, and they are also easily distracted. Impulsivity is the tendency to act in response to immediate stimuli without thinking first, so acting out first before thinking, and then afterwards thinking, well, maybe I should have thought about it and then decided otherwise. And hyperactivity is something that occurs very often in children with ADHD, but hyperactivity gets less and less once the children get older. And we still have some hyperactivity in adult patients, but most of the patients describe it as a feeling of inner restlessness. So being driven by a motor that is always running, and not so much the real physical motor activity. It's still a problem that emotional dysregulation is not part of the official criteria, because emotional dysregulation affects up to 1/3 of patients with ADHD, and it can be highly disrupting. It can be highly problematic for their everyday functioning. If you have outbursts at work, for example, it's difficult to make this up again. If you're screaming and yelling at your boss, maybe you lose your job. This can resemble borderline personality disorder. This can also be a comorbid or differential diagnosis of borderline personality disorder, but it can also be a symptom of ADHD, and it gets better with ADHD treatment. The prevalence of ADHD in childhood and adolescence is about 5% in the general population. In adulthood, about 3%, because some ADHD symptoms wane off, and although there are still deficits in adulthood, the full criteria are not fulfilled by some individuals. But the question still is it real that we have ADHD in adults? And I think this study is very important to keep in mind, because for a long time, also due to ICD-10, we thought that ADHD is a childhood disorder. And once people turn 18, the disorder disappears, which never is, nothing in life is like that. It's never black and white. So this study shed some light on this, and this is very interesting because it showed that in adolescence, ADHD symptoms can fluctuate. So at some point in your developmental period during adolescence, people have more ADHD symptoms, and sometimes they have less ADHD symptoms. About 2/3 of the people that were included in the study had this, what the authors said, named it fluctuating remission. So sometimes they had a remission and sometimes they didn't. So sometimes they didn't have a full criteria fulfilled for ADHD, and sometimes they did. And what is also very important is that 90% of the individuals with childhood ADHD had deficits as adults, even though sometimes you wouldn't call it a ADHD or a disorder in general, but 90% had deficits as adults that differentiated them from individuals without ADHD. So this can have a very long and lasting impact on individuals. And because I'm specialized in ADHD and substance use disorder, this is my topic. And if I go to a party and people talk to me, what do you do? And I tell them what I do, then very often people tell me, well, ADHD, is it really a real disorder? Isn't it made up by the pharmaceutical industry? And I think the most important reason why ADHD is a real disorder is you can die from ADHD. Of course, you don't die from ADHD because ADHD is a disorder that comes with a lot of deficits. It doesn't come with life-threatening symptoms, but the consequences of these symptoms, they can be deadly. And this study showed that if individuals receive an ADHD diagnosis before the age of 12, their mortality risk is increased. But it's even more increased when you get the first ADHD diagnosis as an adult, so about 10 times. I think this is not because early diagnosis saves lives, but reduces mortality, but I think this is because early treatment could save lives. And the highest rate of mortality, the highest mortality risk in this study was in the group of individuals with ADHD and comorbid substance use disorder, which was about 8 times higher as the ADHD only without comorbidity group. And the reasons why individuals died in this study were accidents and so-called natural causes of death, which is stroke, heart attack, which is, very often are these disorders, are these fatalities, well, the consequences of substance use, alcohol use, tobacco use, cocaine. They all can lead to heart attacks and strokes, for example, and also cancer. And suicide was also a cause of death in the ADHD group. ADHD is stigmatized because if I go to parties and talk about my topic, then I very often hear also that ADHD, well, it's a real disorder. Okay, you're right, but ADHD is totally overdiagnosed. Everyone nowadays has ADHD. This, and also that, well, ADHD, individuals with ADHD, they should, work out, they should engage in sports, they shouldn't take any medication just to calm themselves. They shouldn't take any sedatives. Then very often individuals here, pull yourself together, which is never a good advice for anything, because pulling someone together doesn't lead to anything good. But the behavior still is disturbing. There are studies that gave them case vignettes. People of the general population were presented case vignettes, and they described typical ADHD symptoms. And they asked, would you like these individuals to care for your children, to have them as a neighbor or as a spouse, or to have them as a working colleague? And they all said, hell no, I don't want anyone that is hyperactive and is unable to focus and forgetful and misses appointments and all of that. I don't want that behavior next to me. It's disturbing. And I want to be away from them. So this makes it very difficult for the individuals with ADHD to do the right thing. Because if they say, I have ADHD and I receive treatment, then they hear, you should pull yourself together and do some sports, don't take the medication. But if they don't take the medication, then they are hyperactive, impulsive, inattentive, and then people try to get away from them. So either way they choose, they do it wrong. Now we want to talk about the reasons why ADHD and alcohol use are so connected, so interlinked together. And one reason is because ADHD can lead to traumatic experiences. As I said, accidents, car accidents, for example, are you have a much higher risk for car accidents if you're inattentive and impulsive. Of course, and you also have much higher risk for traumatic experiences when you're drunk. Young women going home with a group of men they didn't know before when they are drunk, for example, or driving cars or other vehicles while you're drunk. That increases risks of traumatic experiences. ADHD and alcohol use increases the risk for traumatic experiences, and traumatic experiences can increase the risk for ADHD. So subclinical ADHD symptoms can be aggravated by traumatic experiences, and of course, alcohol use helps to deal with, or helps is maybe too much, but alleviates traumatic experiences a little bit. So that's a vicious circle there. Another vicious circle is brain injuries that can that appear that ADHD people suffer more often from, but also brain injuries aggravate ADHD symptoms. And if you're drunk, then you also have a higher risk for brain injuries. And if you had a brain injury and you drink too early, then this can this can worsen your cognitive outcome. So there's also another vicious circle. And impulsivity is also very important, I think, because individuals with ADHD are more impulsive than others. And if they engage in binge drinking during adolescence, then they get more impulsive. Binge drinking adolescents have higher impulsivity. They increase their impulsivity with this neurotoxic alcohol use. And so if you have ADHD, then you have a higher likelihood of binge drinking. If you do a lot of binge drinking, then your impulsivity gets higher, which also in turn increases your alcohol use, and so on and so on. So this is also a problem here. And all of these and many more things lead to quickly escalating alcohol use. So individuals with ADHD, they start about the same age with their first alcohol use. It depends more on society and legal issues. But they escalate their use much earlier, and so this leads to an 8 years earlier alcohol dependence compared to those without ADHD. This is highly relevant because if you think about alcohol use disorder, alcohol dependence, then you think about individuals that are about 30 years old or 40 years old or so. But in ADHD, it appears to be 8 years earlier. So where leads us this? I said 3% in adulthood have ADHD in the general population. In substance use disorder patients, it's 15 to 20%. It's a huge increase. This is only topped by the rate of undiagnosed ADHD in individuals with substance use disorder. This was one of my studies that found 94% of individuals with ADHD and alcohol use disorder did never before receive an ADHD diagnosis. So there's a lot of to do for us and for you out there. And why is it relevant that we diagnose, that we identify individuals with ADHD? Well, first of all, alcohol use escalates early and leads to early dependence. So this is always a problem if you don't have a good developmental period where you learn how to deal with emotions and problems, and where you can have a good academic education, for example, but instead drink to solve all your problems. That's very problematic because you don't have any other problem-solving skills. Then you have a very high risk for comorbid disorders. Treatment discontinuation is very a common problem in individuals with ADHD and alcohol use disorder. They drink more often during treatment, also during inpatient treatment, and they have problems with rules because they are impulsive and inattentive. So maybe they got thrown out of the treatment. They are impulsive and do not like to wait. They have problems with organizing themselves, so they miss appointments, and yeah, that's that. So it's hard to get these people into treatment and to keep them in the treatment. That's more or less what the slide says. And this is why we emphasize the need for routine screening for ADHD in individuals with alcohol use disorder. This is recommended by international consensus statements published by ICASA, and also by the German S3 guidelines for alcohol use disorder. Also, it will be in other German guidelines. So these are national guidelines, state of the art, how you should treat alcohol use disorder. And there it says you should screen for ADHD because it's very common. It's very commonly not identified before, and it's very relevant for the treatment outcome. But I have to say that a positive screening for ADHD does not mean it's a diagnosis. So a single questionnaire could never make up a diagnosis. This is not a diagnosis. This is a positive screening result, and it needs further diagnostic assessment. A negative screening doesn't mean ADHD is ruled out, but it means that ADHD diagnosis is unlikely. And I recommend ADHD, for ADHD screening, I recommend the ASRS because it's quite short. It has 6 items that are very easy to fill out, because if you have ADHD patients, they always will forget 1 or 2 items to fill out. And it's also very convenient for the physicians, for a psychotherapist, a social worker, because it's easy to build a sum score. You just everything that where the patient made a cross at never, you give 0 points, and very often you give 4 points, and then in between is in between, and then you build a sum score. But if you use a normal sum score of equal to or larger than 14, then you would miss 1/3 of the cases. So this is contradictory to some people, maybe, because many times I hear, oh, alcohol use disorder patients, substance use disorder patients, they all want ADHD, they all want amphetamines. It's the opposite. They have a very bad self-insight. They do not know their symptoms very well, and they tend to underreport their symptoms. And this is why I recommend using equal to or larger than 12. Then you have about 1/3 positive ADHD screenings that are actually no ADHD diagnosis, but something else. What you want to do, I cannot tell you. It depends on the resources that you have and the focus that you have on ADHD. Anyway, doing a screening is much better than doing nothing. So don't get lost in which sum scores should you use. Just use a screening and use it frequently, and you will find many cases and help many patients to improve. This is a very interesting study, I think, because we tried to assess the hyperactivity or ADHD symptoms in individuals with ADHD and alcohol use disorder, and only with alcohol use disorder, in an objective manner. So they had this computerized concentration task, more or less, and we had an infrared camera installed that was filming their head and trying to see if they have a lot of head movements during this concentration task. This test is commercially available. It's a QB test. And QB test hyperactivity showed no differences in all 3 diagnostic groups. But self-reported hyperactivity, so a simple questionnaire, showed significant differences between individuals with alcohol use disorder. They had the lowest hyperactivity, and ADHD, and those with ADHD and alcohol use disorder, they were even more hyperactive than the ADHD group in self-report, but we couldn't objectively measure it. And this also is very an important take-home message. Don't try to diagnose ADHD from looking at the patients. You won't find many that are objectively hyperactive. You won't find it that much in adults. You need to ask the patients, as with any other psychiatric diagnosis. So how should you do diagnostic assessment? I think this is also very important, and this is backed up by international consensus statement and also backed up by the German guidelines. Diagnostic assessment can be initiated before abstinence is achieved. There's a German word, I'm sorry about that. But the diagnostic assessment can be initiated. This doesn't mean that if a patient is drinking, for example, 1 liter of vodka each day, then you can make an ADHD diagnosis. I wouldn't want to do that. I would want the patient to be abstinent first, but you can ask the patient, for example, to bring in some childhood, some proof that they had childhood symptoms, for example, or you can talk to them about their childhood, depending on how much they drink, of course, but you can start the diagnostic assessment before abstinence is achieved. And the final diagnosis should only be made after the medical withdrawal, so after they had a detoxification. But shortly after, you don't need a couple of weeks or a couple of months of abstinence to be sure to diagnose ADHD. Once the intoxication and withdrawal symptoms are have disappeared, then you can make the diagnosis quite reliably. And it's important to make the diagnosis as early as possible in the treatment process, because you would want to treat both disorders at the same time, more or less parallel. And what is also important is that longitudinal assessment of symptoms. ADHD is apparent from the early developmental period. So you have ADHD as a child, and then you have it as an adolescent, and then you have it as an adult. So this is kind of a thing that starts with your life, and you have always been like that, or they have always been like that. And so the longitudinal assessment makes it very easy to differentiate between episodic disorders and ADHD, for example, like episodic depression or bipolar or so. This is one of the recent studies that we did with ICASA. It's the largest prospective study on ADHD and substance use disorder. It was a naturalistic study where we included a lot of patients with ADHD and substance use disorder. Almost 600 we included. Most of them had alcohol use disorder, but also stimulant, cannabis, opioids. This does not mean that these are the main substances that individuals with ADHD use, but this means that these were the substances that were treated in the participating centers. And I think this is quite important because 70% had previous substance use disorder treatment, and all of these centers, they had sometimes decades-long experience in identifying and treating ADHD and substance use disorder comorbidity. But although 70% of the individuals that we included had previous substance use disorder treatment, 40% never had ADHD treatment before. And we always say that treatment is so important, but maybe we are not so good at following our own recommendations, I have to say. The most prevalent comorbid disorders that were not actively diagnosed, but these are clinical disorders, were depression, post-traumatic stress disorder, and borderline disorder. Childhood with ADHD is stressful for all that are involved, so for the children and for the parents as well. Children with ADHD very often, because due to the high heritability, had parents with ADHD. So the children experience broken homes, so parents that that separate, parental substance use. They get punished for impulsive behavior because parents do not know how to help themselves otherwise. This can also lead to physical punishment, and they are being stigmatized, as I said before. Treating is being stigmatized, treating ADHD is being stigmatized, and having ADHD symptoms is being stigmatized. And this study is quite interesting because it shows that if you treat children with ADHD with stimulants, with methylphenidate, then you can significantly decrease the risk of physical abuse by the parents. So you can prevent physical abuse, physical harm to the children by treating their ADHD. This doesn't mean that the children are responsible, that they, it's their fault that they get hit. No, of course not. But that's always the problem in child and adolescent psychiatry. You never have a mandate to treat the parents, but you have a mandate to treat the children. And this does not only improve their ADHD, but also improve secondary outcomes like being hit by your own parent.
Matthias, can you try to finish in 5 minutes?
5 minutes should be doable. Then I skip this. I think post-traumatic stress disorder and alcohol use disorder is more common in individuals with ADHD. That's the key message. And there are a lot of differential diagnoses and also comorbid disorders that need to be addressed, but most of them are more comorbid disorders than real differential diagnoses. This is my experience. Good. And now about the treatment. I think I need maybe not 5, but 7 minutes, if that's okay. Good. Because I think treatment is quite important to address. Stimulants are the main treatment for ADHD. They are highly effective, but they are less effective in ADHD plus substance use disorder. And of course, treatment adherence is not good in individuals with ADHD and not good in those with substance use disorder. And you have to be aware of the risk for diversion. So giving stimulants to others that didn't get the prescription, and misuse of stimulants also. But the comorbidity has negative effects. Psychotherapy would be so good. You cannot abuse or divert psychotherapy. It would be so good if this would be helpful, but psychotherapy for ADHD and substance use disorder did not show any real benefits. Non-stimulants did not show any real benefits that are clinically relevant. Atomoxetine was here the non-stimulant. But stimulants in ADHD and substance use disorder showed promising results in retrospective studies. So improved treatment retention, also in some in amphetamine use disorders, it reduced the risk for hospitalizations and also mortality. So this is quite interesting. Maybe there is something. And we have two well-done studies, well-done RCTs One is on osmotic release methylphenidate plus cognitive behavioral therapy in amphetamine use disorders patients with ADHD that started in prison. So maybe a population that you wouldn't want to make a study about because you would expect very negative results. But you had in the Verum group and the methylphenidate group, you had at the end more negative drug urines compared to the placebo group. So this is very good. And also a better adherence. Same applies to cocaine use disorder with ADHD, treated here with amphetamines plus cognitive behavioral therapy. This is also important. So for alcohol use disorder and ADHD, this leads us to long-acting stimulants are first line, non-stimulants are second line. So we treat with stimulants first. Of course, there is a risk for misuse and diversion. We don't know exactly how large this risk is and who is at risk, but long-acting stimulants have a limited risk for these negative effects. And it's very important, ADHD treatment does not improve alcohol use disorder. It improves ADHD, and this makes it more easy for the patient more easy to benefit from substance use disorder treatment and to take their medication for other comorbid disorders and do not forget the medication. So ADHD treatment is essential, but it only improves ADHD. Good. I skipped this, and this is a summary. ADHD is common in alcohol use disorder, but it's rarely recognized, and this is on us to change that. We need to focus more on this and to help the patients identify their symptoms. Routine screening for ADHD is therefore recommended in individuals with alcohol use disorder, and common comorbid disorders are post-traumatic stress disorder, personality disorders, also depression and bipolar. And long-acting stimulants, as I said, are first line. Non-stimulants are second line. Sometimes you need to find individual safety measures when prescribing stimulants. For example, individuals that have problems taking the medication as prescribed, they probably can show up at the treatment center like once a week or twice a week to get their medication. So they don't have too many pills at home, but this applies only to some individuals. So large majority does very well with the usual prescription. And medication is always in combination with substance use disorder therapy plus therapy of the comorbidity. So that's it. Thank you.
Thank you, Matthias.